Hi everyone, welcome to Imaging Study Lecture Series. Our today's topic is Biophysical Profile, in short known as BPP. This lecture will cover some introductory talks, history of biophysical profile, its components, indications, patient preparation, scoring technique and management according to the scores, ideal time for biophysical profile, factors affecting biophysical profile. We'll also know about modified biophysical profile, and at the end we will compare it with vascular duplex. This lecture is made especially to help the radiologists, sonologists, obstetricians, pediatricians, residents and new doctors. Before I start my today's lecture, I would love to request you to consider subscribing our YouTube channel and follow us on other social platforms. It will help our channel to grow and will help more people to learn. All the links are given on the description below. After each delivery, we commonly check the neonatal well-being using Apgar scoring system. If the baby's condition is not suitable, we usually transfer the neonate to intensive care unit or refer it to a suitable specialized center for a better management. If we could check the fetal well-being or could exclude the chance of asphyxia before birth, then the rate of neonatal morbidity or mortality might be controlled more easily. Do you know how to exclude hypoxia before birth? Well, that's what we are going to learn today. In 1980, Manning and his colleagues developed biophysical profile scoring to assess fetal well-being. They fashioned a method for fetal surveillance in high-risk pregnancies that combine fetal heart rate monitoring with various ultrasound-derived variables. Their technique was later modified by various scientists to make it more easier and time-consuming. 5 biophysical parameters are assessed individually and in combinations. Each separate test has a high false positive rate that is greatly reduced when all the variables are combined. Each of the 5 categories represents a separate mini-evaluation of fetal behavior or function, which we will discuss later. These are a combination of acute and chronic markers. These 5 components of biophysical profile are cardiac non-stress test, known in short as NST, fetal breathing movements, fetal gross body movements, fetal tone, and amniotic fluid volume. Are all 5 parameters checked with ultrasound? We'll know it later. Modeled after the Apgar score, 2 points are awarded in each of the 5 categories for reassuring results, and no points for a non-reassuring result. So the score always comes as even numbers like 10, 8, 6, 4, 2 or 0. A total score of 8 or 10 is indicative of a fetus that is not intrable, and a score of 6 or less is cause for some concern. Now another question. Can biophysical score become odd in number? Previously, some scientists recommended to use 1 when scoring criteria partially meets. So that gave odd numbers as a result. But this technique is not commonly used. Who are the eligible candidates for biophysical profile? The American College of Obstetricians and Gynaecologists recommends antepartum fetal surveillance with tests such as biophysical profile for pregnancies at increased risk of antepartum fetal demise. This includes oligohydramnios, pregnancy-induced hypertension, intrauterine growth retardation, postdatism, bad obstetric history, Rh incompatibility, gestational diabetes mellitus, elderly primary. Testing begins at 25th week and is done serially. Most referred are tested weekly, but those with severe or unstable condition are tested twice weekly or even more often. Why don't we do biophysical profile on first or second trimester? Do you know the reason? We'll know it later. No definite preparation is needed for biophysical profile. Empty urinary bladder will help measure parameters more accurately. Prolonged fasting state may create false interpretation. A heavy meal before examination will help see fetal movements more easily. This will also reduce examination time. Vibroacoustic stimulation, maternal movement, manual manipulation of the maternal abdomen, ingestion of orange juice help awaken or stimulate a non-reactive fetus. The acoustic stimulator is essentially an artificial larynx that generates mixed frequency sound at rather high intensities. It's like walking behind some unsuspecting person and buzz him or her with boom. This also can create fetal hyperactivity for many minutes. I better love to choose other ones. Patient is examined in supine position. Technique is same as third trimester regular pregnancy scan. We just need to see some special points which we are going to describe now. Cardiac non-stress test is done on a separate machine called cardiotachometer or cardiotachography machine for continuous monitoring of the fetal heart rate. Biophysical profile is a time-consuming procedure. For an accurate report, your patience is very important. Scanning time depends on the fetal condition and sleep stage. It may take around 10 minutes to finish, and sometimes it may be extended up to 120 minutes, that means 2 hours. So how busy practitioner are you? Tell me on the comment box below. Now let's start the scoring technique. At first we will talk about the fetal breathing movement. To get a score of 2, there should be presence of at least one episode of sustained fetal breathing of at least 30 seconds duration within a 30-minute observation period. If there is no fetal breathing or absence of an episode of fetal breathing of at least 30 seconds duration during this observation period, then the fetus will be given 0 mark. Now, how to see these breathing movements? There are several techniques for that. You can check the outward and inward movements of the chest and abdominal walls, craniocaudal movements of the fetal kidneys, and outward and inward flow from the fetal nose, putting color Doppler over there. Here I have drawn a picture to demonstrate to you the chest and abdominal wall movements as well as craniocaudal movements of liver, kidneys and diaphragm during breathing. On the left picture, a sagittal cut will help you see the outward-inward movements of the chest and abdomen at the same time. Right one, as it's a cross-section of the abdomen, can also show you the abdominal wall movements on real time. As the next image also shows kidneys, it may help see breathing more easily. Let's check this on real time. Here in cross-section of the fetal abdomen, you can see the outward-inward movements of the abdominal wall due to fetal breathing. We need at least one episode of these movements lasting at least 30 seconds within the observation period to give the fetus a 2 score. Let's see another one. This is a kernel section of the thoracoabdominal region. You can see the movements of abdominal organs as well as thoracoabdominal walls. This is a slight oblique section. You can see the hypoechogenic diaphragm is moving with breathing. Here in a sagittal section, movements of diaphragm, liver as well as thoracoabdominal walls are seen. Another sagittal cut showing movements of diaphragm, liver as well as thoracoabdominal walls. Part of kidney is also seen here. Another video of breathing movements on sagittal and axial sections. An alternate observation is the caudate cephalad movement of the kidneys. In my practice, I use this more. Fetal kidneys can be easily visualized on sagittal section. First try to see the spine in sagittal cut, which is quite easy. Then move the transducer slight laterally as the kidneys lie lateral to the spine. I love to magnify the image using zoom button and then wait to observe the kidney movements. Kidneys can be easily identified by its shape, less echogenicity of parenchyma, and no doubt the pyramids. In this picture, you can identify a kidney and we want to see its craniocaudal movements. Let's see on real time. This is the fetal kidney and you can see good fetal breathing movements. Whoa, you just watched a gross body movement. Now you can see the fetal kidney moving craniocaudally. You can also see the chest wall movements here. We can see kidney moving here beside the spine. We also can see the diaphragm and body wall movements. A magnified view of moving kidney. Stomach is seen nearby. Again, good kidney movements. Also, body wall movements are seen. Again, kidney and liver movements. Kidney moving here beside the spine. Again, a kidney movement. You can see the abdominal aorta and inferior vena cava here. A moving kidney. Hepatic movement is more pronounced here. Kidney movements again. You can see thoracoabdominal walls as well as kidney movements here. Long video session. My plan was to make your eyes accustomed with breathing movements. It's easy but commonly mistaken. Last option for breathing movement is to use color Doppler. During respiratory movements, amniotic fluid enters and exits through the nostrils. If we put color Doppler box over the fetal nose, we will see red and blue flows at nose during breathing. On the right, you can see the red flow coming out of the nose, as red indicates towards the transducer flow. Let's check it on real time. Here you can see color flows from the nose on a sagittal section of the face. A cord is seen in front of the nose. When I tried to see by zooming, the baby moved and destroyed the view. Now come to the next topic, gross body movements. In short, this is the fetal movements we usually check during routine obstetric scans. To give a 2 score, presence of 3 or more gross discrete body or limb movements during 30 minutes examination period is required. If there is no or less than 3 body or limb movements during this observation period, the score will be given 0. You can see and count gross body movements during fetal biometry to save your scanning time. As example, you can see trunk movements during SU measurement, head movements during BPD, chest movements during heart rate estimation, limb movements during FL measurement. Let me make you more clear. You can see the cross-section of the abdomen on the left. Spine is seen on the midline. The fetus moved and now you can see the spine at around 2 o'clock position. So you can count it as one gross body movement. Check on real time. Here you can see a good fetal trunk movement. I tried to take a view for abdominal circumference and the fetus started fighting. Here we can see a fetus jumping. Sleep is over, fetus is getting ready to get out of bed. Here respiratory as well as slight body movements are going on. Now come to fetal tone. Most common mistake we make on a biophysical profile report is giving the tone a 0 score with 2 for each other. We'll make some discussion about sequences later. To give a 2 score, in short, we have to see at least one tone during 30 minutes observation period. If we can't see that and fetal spine and extremities remain on extension state for that duration, we will give the fetus a 0 mark. Now how to see a tone? We want to see a joint extension from a flexed state and then returning back to flexed state. If the joint is in extension state, then for a tone, it should get flexed first, then extension, then flexion. So this is a little disturbing topic. That's why I say to remember flexion, extension, flexion as a tone. Now where to see these movements? Any joint you want, in my opinion, to make it easier. Manning and his team suggested to see these on spine. Well, sometimes that may not be enough to give mark. So you can see flexion, extension, flexion of knee, elbow, wrist or ankle. Opening and closing of the hands can also be counted. Sometimes 3D 4D ultrasound may help see tone. Remember that to see tone, amniotic fluid plays an important role. So oligohydramnios may cause an inappropriate result. We will try to apply some tricks to get rid of this problem. Here on the left, you can see a flexed spine with a good convexity. Suddenly, you will see the fetus to move and spine will lose its convexity. It will become quite straight like we can see on the right one. You can also see extension of the fetal neck sometime. While watching this part, you should also try to extend your neck and practice tone on yourself. Trust me, it's a good way to learn. Now on these 3D images, the baby is feeling shy to show us its face. You can see the closed fingers on the left and open on the right. Closing, opening, then again closing is counted as a single tone. So that's easy. You just need to see a single tone during examination period. Next, we can see a flexed knee on the left and sudden extension on the right. To understand tone, sometimes you can use another technique. While measuring femoral or humeral length, this technique may help you observe tone. On the left, you can see the 2 leg bones on cross-section. On the right, you can see a leg bone of same fetus on long section. This change has 2 reasons. Either you have rotated your transducer or fetus has changed the joint from flexion to extension. So open a joint. wait for the desired moment, and boom! Let's see on real time. First one, foot and legs are seen, knee is flexed. And it is extended now. Again got flexed. Again fetus has extended the knee and flexed. So now you have to practice a lot to identify these views. Here a flexed spine. Slight flexion, extension flexion is going on rapidly. I don't know whether you could understand or not. Look at the fingers. Can you see tone here? Here we can see a placental hematoma. You can see tone on upper limb as well as good fetal movements. It's very early case for biophysical profile, but we used it to demonstrate normal movements. We commonly use amniotic fluid index or AFI to assess amniotic fluid volume. But for biophysical profile scoring, the amniotic fluid measurement technique is slightly different. To give a score of 2, there should be at least one amniotic fluid containing pocket which measures at least 2 cm on 2 perpendicular planes, that is horizontally and vertically. If can't find that, then the score will be given 0. Let's discuss it more. To see the amniotic fluid, always keep your probe longitudinal. Never press over the mother's abdomen, just touch gently with your probe. And make sure the bladder is empty. For AFI, we search for 4 pockets within 4 quadrants and take a summation of the vertical measurements of those pockets in centimeter, excluding fetal parts and cord. There is another measurement technique, that is the single deepest pocket measurement or SDP. Here we take the deepest vertical diameter of the largest pocket, which should not be less than 2 cm. For biophysical profile, it's quite like SDP. The difference is that the pocket should be 2 cm or more, not only vertically but also horizontally. Here I have shown you some fluid-filled pockets from different quadrants. Let's see a pocket on real time, and then we will see the measurement technique. Here you can see a fluid-filled pocket. Placenta is seen posteriorly. Fetal part is seen medially. Now let's check how to measure it. Here I have measured a pocket. You can see the highest vertical and horizontal diameters are 4.3 and 3.2 centimeters respectively. If you can find at least one pocket which fulfill this criteria, the fetus will be given a 2 score. Here I have given some more examples. Make sure the lines are perpendicular to each other. The original definition of oligohydramnios by Platt and Manning was the absence of a pocket of fluid of at least 1 cm in any vertical plane. This requirement has been loosened to 1-2 cm pocket, for which 2 points are awarded and below which no points are given. Some centers have converted over from the vertical pocket definition to an AFI of less than 6 cm for a score of 0. Okay, that's all for ultrasound work. Now come to the NST, cardiac non-stress test, to see the cardiac reactivity. To give a score of 2, there should be presence of 2 or more fetal heart rate accelerations of at least 15 beats per minute, lasting at least 15 seconds during 40 minutes examination time. So that's not easy to remember. Fortunately, you don't have to do it with ultrasound. If we see no or less than 2 acceleration during this time, then the fetus will be given 0. On ultrasound, we freeze the image and then measure the heart rate. We can't monitor fetal heart rate continuously with ultrasound, and due to fetal movement, it's not easy to monitor continuously also. So we use a separate device, cardiotachometer or cardiotachography machine, to monitor fetal heart continuously for 40 minutes. Yes, 40 minutes. Machine will provide you a 40-minute tracing. Some centers also take 20 minutes reading. It gives both qualitative and quantitative description of uterine activity, that is contractions, baseline fetal heart rate variability, presence of accelerations, periodic or episodic decelerations, changes of fetal heart rate patterns over time. Let me make it more clear. During a non-stress test, uterine contractions and fetal heart rate monitoring occur through the use of a cardiotachometer and Doppler. I have shown here some CTG machines. It's quite like ECG procedure. The patient presses a marker whenever she observes fetal movement. The cardiotachometer records a pattern of fetal heart rate. This includes both a baseline heart rate and any periodic changes, in particular accelerations or decelerations from the baseline rate. The tracing comes like this. If I want to explain you with your ultrasound knowledge, think that a fetus has a heart rate of 140 beats per minute at resting stage. This is the baseline rate. Suddenly the heart rate will be increased more than 15 beats. That means you will see the heart rate is now more than 155 beats per minute. This will stay like this for more than 15 seconds. And then we'll get back to the baseline state, that is 140 beats per minute. Now, to get a score of 2 on biophysical profile, this event should happen at least twice within 40 minutes examination period. That's really difficult to memorize. Thanks to our obstetricians for interpreting that for us. Okay, now a question. Have you got a CTG machine in your hospital or working place? It's not available everywhere in my country. Let us know making a comment on this video. We want to hear facilities you get. Now, what will our physician do with our report? If the score is 10 out of 10, we hope it's going to be a normal infant with low risk of chronic asphyxia. As we are dealing with a high-risk pregnancy, so we need to repeat the test at weekly intervals. Repeat biophysical profile twice weekly in diabetic patients and patients with more than 42 weeks of gestation. If the score is 8, again it should be a normal infant with low risk of chronic asphyxia. Repeat the test at weekly intervals. Repeat twice weekly in diabetic patients and patients with more than 42 weeks of gestation. You see that you have put 0 for a parameter. That's why it's 8. Now, if it's amniotic fluid volume who got 0, that means oligohydramnios, then it is an indication for delivery. 6 score. Suspect chronic asphyxia in this case. If it's 36 weeks or more with favorable condition, then go for delivery. If it's less than 36 weeks of gestation and lecithin sphingomyelin ratio is less than 2, then repeat the test in 4 to 6 hours. Deliver the baby if oligohydramnios is present. Score is 4. Things are getting worse. Suspect chronic asphyxia here. If it's 32 weeks or more, then deliver. If it's less than 32 weeks of gestation, then repeat the test in 24 hours. If repeat score is below 4, then regardless of gestational age, deliver the baby. Neonatal ICU support will be required here, so keep it on mind before delivery. 0 or 2 score. Very poor condition. Strongly suspect chronic asphyxia. Extend the examination time to 120 minutes. If persistent score is not more than 4, regardless of gestational age, deliver it. We have finished our main discussion. Now we will solve some confusions. Firstly, why are we using these parameters? The fetal heart rate, reactivity, breathing movements, body movements, and tone are acute markers and are altered by acute hypoxic changes. If you look at the central nervous system centers, tone is controlled from cortex or subcortical area. Body movements are regulated from cortical nuclei. Breathing is controlled from ventral surface of the fourth ventricle. Cardiac acceleration is regulated from posterior hypothalamus and medulla. Hypoxia at these regions will cause loss of respected features on biophysical profile. The chronic marker of fetal condition is amniotic fluid. It is an indicator of chronic fetal distress and is associated with reduction of fetal cardiac output away from non-vital organs, resulting in blood being shunted away from the kidneys. This results in less urine production and ultimately oligohydramnios. The oligohydramnios seen in postpartum pregnancy may represent an exception to this brain-sparing concept. Here there is evidence to suggest that there may be a direct effect on the kidneys rather than a stealing mechanism employed by the brain. My next confusion is why we do biophysical profile at third trimester only. As we see, it's an excellent investigation to assess fetal well-being. Why don't we do it on second or first trimester? Let's enter into embryology. The fetal tone center develops at 7.5 to 8.5 week. The fetal movement center develops at 9th week. Regularized diaphragmatic motion develops by 20 to 21 weeks. Heart rate reactivity is the last to develop. It appears by the late second to early third trimester. That's why doing biophysical profile before third trimester has a high error rate due to undeveloped centers. We will learn a trick now. Centers developed later are more sensitive to acute hypoxia. For example, the loss of cardiac reactivity and suppression of fetal breathing movements would occur with relatively mild hypoxia. Cessation of fetal movements and eventually loss of fetal tone would occur with progressively more profound hypoxemia. So in short, we can remember that early to appear, late to disappear. While we are discussing fetal tone, I have told you that absence of tone is the common mistake on biophysical profile reports. When you are giving 0 score on tone, make sure there is no breathing or body movement. We can think on a reverse way. If we can give 2 scores for breathing movements on ultrasound, definitely there is presence of body movements and tone. This trick will not only reduce your examination time on emergency situation, but also help you overcome that common error. So don't forget, early to appear, late to disappear. Now my last question, why so long observation period? Why 30 minutes? Why not 10, 20 or 40 minutes? Although many investigators have contributed to knowledge of fetal behavior, John Patrick was the one who used ultrasound continuously for many hours to correlate fetal heart rate changes with fetal respirations and movements in an effort to correlate these with fetal sleep states. There are 4 fetal sleep states, 1F through 4F. Sleep state 1F represents quiet sleep. During this time, fetus moves little, breathes infrequently, and has a heart rate that is generally devoid of significant accelerations. To term, the fetus spends about 25 to 30% of the time in sleep state 1F. So if you get the fetus on this state, you are doomed. Pause the video here and return back to patient preparation discussion I made if you want to get rid of quiet sleep state. State 2F represents a period of active rapid eye movement sleep, during which time the fetus actively moves, breathes, and has increased beat-to-beat variability of the heart rate and displays heart rate accelerations. This occupies about 60 to 70% of the fetus time in late pregnancy. Both 3F representing quiet awake sleep and 4F or active awake sleep help finish our biophysical profile easily, as we can understand by their name. But unfortunately, they comprise only 3% of the fetus's activity. The biophysical profile is affected by the first 2 major sleep states. For example, non-stress tests are often non-reactive during quiet sleep, and respirations and body movement are normally depressed during this time. This is why one often has to be patient while performing a biophysical profile. John Patrick found that quiet sleep usually does not last more than 20 minutes. This is why the testing length of 20 minutes was initially chosen. But occasionally a normal fetus can frustrate the observer for more than 40 minutes. That's why we adjust the examination time to 30 minutes in general. It is important to mention that factors other than hypoxia can affect the variables of the biophysical profile. Various drugs such as narcotics, tranquilizers, alcohol, cigarettes, maternal anemia causing hypotension, fasting state will depress the fetal heart rate variability, respirations, and movement. Maternal hyperglycemia can increase fetal movement and respirations. The modified biophysical profile also came into being as a pragmatic substitute for the full biophysical profile. It consists of a non-stress test and an evaluation of amniotic fluid. The non-stress test assesses the fetus for acute hypoxia, and the amniotic fluid speaks for the chronicity of the problem. We have already said that the cardiac reactivity is the first parameter to get affected in hypoxia. D.A. Miller found a false positive rate of 60% with this test, but a 0.08% false negative rate. This modified technique significantly reduces examination time and helps take rapid decision by the clinicians. Here is a flowchart for obstetricians about how they can manage the case based on modified biophysical profile. If non-stress test is reactive and amniotic fluid is adequate, then repeat the test twice weekly. If non-stress test is reactive but there is oligohydramnios, manage according to amniotic fluid volume if fetal breathing movement is present. If fetal breathing movement is absent but you can see normal body movement and tone, then extend non-stress test to 120 minutes or do biophysical profile or go for computerized fetal heart rate monitoring. If all biophysical activities are absent, then deliver as soon as possible. For non-reactive non-stress test, do real-time ultrasound evaluation to check all other parameters and according to them take decision. Nowadays, we are trying to focus more on obstetric Doppler than biophysical profile. Vascular duplex takes less time in comparison to biophysical profile. It can predict fetal hypoxia earlier, making it easy to take decision. Also, it can be used before third trimester in some cases. Clinicians are sending patients for biophysical profile with obstetric Doppler nowadays. We will finish our long lecture with reporting. It actually varies widely depending on institutes, so try to follow your one. I'm trying just to give you an idea in general. You need to put your general fetal biometry and normal obstetric ultrasound report containing number, presentation, lie, placenta, fluid, etc. Then for biophysical profile, firstly you mention the test duration. It is important. You already know that there is a huge difference of fetal state between 10 minutes and 120 minutes testing times. So don't hesitate to put the accurate time. Then I have mentioned the tests, their findings, scores achieved, and normal parameters in short. These short normal parameters have some values. You see, it's difficult to memorize all those normal values. If you don't practice biophysical profile frequently, you will forget these very quickly. So on this situation, when you get a patient for biophysical profile, just open the report, have a quick look at normal values and start the test. Another point, if you have time on your hand, practice at least one parameter in every obstetric case. It will help memorize these parameters more than watching this video repeatedly. Also, mentioning normal values help our clinician understand the report on a better way. So, our total score on ultrasound will be 8 by 8, 6 by 8, 4 by 8, 2 by 8 or 0 by 8. Our clinicians will do NST and add that score with ours for a final score. On impression, in short, we can write about ... weeks of single live intrauterine pregnancy with cephalic presentation and adequate liquor, and fetal biophysical profile score is 8 out of 8. Well, that's all for today. If this video helped you, then don't hesitate to share with your friends. You can subscribe our YouTube channel and hit the bell icon for more contents. I have mentioned reference books on the description box. Please comment your impression about this handwritten lecture concept. Should I continue this type of lecture or should go for PowerPoint presentation? I will wait for your response. Thank you all. See you on next video. Stay safe at home. and have a nice day.